Hello, everyone. Welcome back to Karan Academy. My name is Karan, and I hope you're all doing super well. Today, we're going to be wrapping up our series on hematology with a few bleeding disorders. So now, instead of just going through bleeding disorder A, bleeding disorder B, I've gone into a bit more depth as always, and this is a bit extra. I'll let you know what's important for your year level, but I think having broad understanding of the coagulation pathways, as horrible of a revision as that is, I think is a bit relevant here. So let's jump into it. Starting off nice and easy, what is hemostasis? So it's a fine balance between stopping bleeding when, obviously, if you bleed unnecessarily, but also letting blood flow and do its job, which is end tissue perfusion, right? You need to know what the procoagulants and the anticoagulants in your body usually are. So the subendothelium is a procoagulant, while the endothelium is an anticoagulant. Does that kind of make sense? Under normal circumstances, the endothelium, which is normally exposed to blood, should be an anticoagulant because you don't want to be having excessive bleeding, right? However, if you have undergone hemorrhage or trauma, and now for some reason the subendothelium is exposed, you do want that to be procoagulatory because that is going to help stop excessive bleeding. And we'll talk about how all the others fit in as well. So the three main stages of the hemostatic process, firstly, you have vasoconstriction. Secondly, you have primary hemostasis, and then secondary hemostasis. So let's talk about all of those. Step one, you have your normal vessel. As you can see here, you have the site of injury. Because of this injury, the subendothelium is now going to be exposed to blood flow, and that's going to release a chemical called endothelin, along with some other vasoconstrictors. This is going to result in reflex vasoconstriction using the smooth muscles that are going to be beneath the endothelial surface. And this is going to be good because you would reduce the blood flow distally and therefore would reduce the degree of bleeding almost instantly. Next, we have primary hemostasis, or the formation of the primary platelet plug. So if you look at this picture, so just ignore the text for a hot second. Look at the picture here. So this is your normal endothelial lining. For some reason, you've had damage and shearing, and now the subendothelium is exposed. The subendothelium is full of collagen and other fibrous material and has a binding site called the collagen binding site. You now also have the von Willebrand factor, which is a normal part of your blood and it's going to be present everywhere. The von Willebrand factor is this lovely bridge, and it has two ends. One of them is the collagen binding site, and that's going to go and bind to the collagen that's present in the subendothelial layer. So that's one end. The other end is going to bind to glycoprotein 1b. And that is going to be found on the platelets. So as you can see, it's kind of forming a bridge between the subendothelial layer and the activated platelet. Once the platelet is activated, because of this whole joining process, it undergoes a bit of a conformational change and then releases more chemicals to recruit further platelets. So once again, you have this activation after the binding of the platelet to the subendothelium with the help of the von Willebrand factor. It's going to start releasing thromboxane A2, which is this other chemical. What thromboxane A2 basically does is it induces platelet recruitment. So you now have more platelets coming to this spot and aggregation as well. So now you're going to have a very rudimentary structure where you have tons of platelets clumped together, hanging onto the subendothelium through the von Willebrand factor. And that is your primary platelet plug. What you need to know is this is just platelets to stop the initial bleeding before you have something a bit more substantial coming in and actually closing that plug up. So again, very brief summary. You have damage to the endothelium, subendothelium is exposed, the collagen in the subendothelium binds to the collagen binding site on the von Willebrand factor. The other end of the von Willebrand factor binds to platelets through the glycoprotein 1b subunit. This activates the platelets. The activated platelet releases thromboxane A2 as well as ADP, and this further recruits more platelets to form the primary platelet plug. We'll talk about the coagulation cascade in a bit. When we talk about this, I thought I'd just mention two important medicines that you will almost definitely come across: aspirin and clopidogrel. They both are considered antiplatelet medications and together form dual antiplatelet therapy, which is very commonly used in patients who come in with an acute coronary syndrome or a heart attack, and they tend to be on a dual antiplatelet therapy for a while, especially if they've had a stent put in. The way aspirin works is it inhibits thromboxane A2 through its action on the COX-2 enzyme, while clopidogrel, it inhibits the binding of ADP to the platelet receptor called P2Y12 and therefore prevents platelet aggregation. Now, you don't need to know these specifics, but what I hope to get by this is the fact that neither aspirin nor clopidogrel prevent this initial binding. However, they prevent further recruitment because, as I said, thromboxane A2 recruits more platelets, and the platelet receptor P2Y12 helps with platelet aggregation. So you're going to have reduced recruitment and reduced aggregation. Both of those would help prevent the formation of this primary platelet plug. Next, we have secondary hemostasis. Now, secondary hemostasis is activated by two broad pathways. You have the intrinsic pathway and then you have the extrinsic pathway. So with the extrinsic, let's start with the extrinsic pathway. You have factor 7A, which activates the combination of factor 10 and factor 5 to cleave prothrombin. So anything with the name pro just means that it's the precursor to that substance. So prothrombin means it's the precursor to thrombin. And when 10 and 5 are activated by 7, it cleaves off thrombin to form prothrombin to form thrombin. Thrombin then goes and activates fibrinogen to release fibrin, and then it is this fibrin that forms that secondary plug, and that is your secondary hemostasis. Additionally, you also have the intrinsic pathway composed of factors 12, 11, 9, and then 8, which also contribute. I would not see this being an exam question for your year level, which is obviously very clinical. However, I guess it's still good to know that the intrinsic pathway, and remember this, so a good memory tool is, so you have 12, 11, 9, 8, and 10, right? 12, 11, 9, 8, 10. Good way to remember this is that the last letter is the first letter of the next one. So 12, E, 11, N, 9, E, 8, T, 10, right? The common pathway is 10, 5, 2, and 1. And then the extrinsic is triggered by tissue factor, which binds to factor 7. Now, when we consider investigations for bleeding, there are two main ones we'd consider. Actually, there are three, but two main ones that I want to talk about. We have firstly prothrombin time and activated partial thromboplastin time. Now, both of them are a bit different. So what does the prothrombin time look at, and what does the activated partial thromboplastin time look at? The prothrombin time depends on the extrinsic pathway. So it looks at this entire pathway. So any issue with tissue factor, factor 7, 10, 5, 2, 1 are going to result in issues with a longer prothrombin time. Likewise, the APTT, or the activated partial thromboplastin time, depends on the intrinsic pathway, which is 12, 11, 9, 8, 10, 5, 2, 1. So any issues with any of these factors is going to cause an elevated APTT. If you have an issue where you have both levels being elevated, the APTT is high and the INR or the PT is high, it probably means that there's an issue in the common pathway and not an issue with both sides, although that is still possible. Now, as you can see, I've mentioned both PT and INR here. And you would know that INR is the one that's most commonly used in clinical practice. And you may be wondering, well, why have I mentioned both? How are they different? Let's talk about that. You would know in your preclinical studies that, actually, I don't know if you would, but the way they calculate prothrombin time is dependent on this specific citric acid-based enzyme. What's tricky about this enzyme is that its concentration is very hard to get exactly right and consistent across all clinical laboratories. What this means is that you might have slight differences in the absolute prothrombin time if you compare different path services, right? So what they came up with is this international normalized ratio called the INR. So the way this works is, let's say you have Path Lab A. Path Lab A would take the blood samples of, let's say, 50 normal patients who are known to not have a bleeding disorder and would calculate what their prothrombin time came up as. It would then compare any further blood tests done to this level as the international ratio. And this would tell us how elevated or how low their prothrombin time relatively is. So instead of saying the prothrombin time was, I don't know, 2 minutes compared to the normal that's 1 minute, what they'll say is that the international normalized ratio, or the INR, was 2, which means it takes that person twice as long as it takes the normal patient. And you need to know INRs when it comes to warfarin dosing, because warfarin affects the extrinsic pathway. And all patients on warfarin are required to have regular INRs. And we'll talk about the targets for warfarin therapy in a bit. Likewise, with the APTT, now this is a bit easier to do, so we can use their absolute values. And the APTT is meant to be around 24 to 35 seconds. Do not need to know this. And as I mentioned, if you have an issue with both, it is more likely to be a common pathway pathology, typically factor 5 or factor 10. Now, there's this third test called the Thrombin time, and it's the time taken for thrombin to cleave fibrin out of fibrinogen in the plasma. Not super high yield, but obviously any issues with fibrinogen itself are going to cause an elevated thrombin time. Any issues with fibrin formation or thrombin inhibitors are all going to affect this time. Lastly, you also have the bleeding time, which is a very rudimentary test. What they do is they might just create a small prick and see how long it takes for the bleeding to stop. So genuinely, they take your skin, prick you, and then see how long it takes for the bleeding to stop. Now you might be wondering, well, what does the bleeding time represent? Well, the bleeding time would represent the primary platelet plug formation, and therefore is a better representation of platelet function, because that's what's going to be stopping the first bleeding instead of coagulatory function, which, as we know, kind of sets up a more long-term stable plug. Now, what is a mixing study? Let's say you have an abnormal PT or APTT. This can be either due to a potential deficiency in a particular factor that's causing this, or you could also have antibodies to that factor, and a mixing test helps figure out which one of that two it is. So what happens is we take 50% of, so we take blood, 50% of that is going to be the blood of the patient who we are testing for, who we know has an abnormal PT or APTT, and then 50% is going to be normal blood. We then mix the two blood samples and repeat the test. If the time now becomes normal, it probably indicates that the patient has a coagulation factor deficiency, because the factors of the other person should be enough to clot the entire blood, because you don't need that many factors or that high levels. However, if the time still remains abnormal, it probably means that the pathological patient has antibodies in the serum that are now affecting the factors of the normal blood sample as well. And in this case, we would then go looking for antibodies against specific factors as well as lupus anticoagulants. Now, what's really important to know are the differences between bleeding disorders. So very broadly, we can have disorders affecting the coagulation cascade and disorders affecting platelets. What you need to know, and it comes back down to basic principles, is what the role of each one of those two are. So you need to know that the type of bleeding, firstly, with platelets tends to be more superficial. With mucocutaneous bleeding, this can be around the gums, the mouth. It takes longer for them to stop bleeding, as demonstrated by the bleeding time, while coagulatory disorders tend to be more invasive bleeds. So hemarthrosis, hematomas, intramuscular bleeds, and so on. Petechiae, again, I think of this as, is it a superficial manifestation or a deep manifestation? Well, petechiae appear on the skin, so it's superficial. And we know superficial manifestations are more common in bleeding in platelet disorders, and they're quite rare in coagulatory disorders. In cases of trauma, you have spontaneous bleeding with platelet disorders, which means you don't stop bleeding, versus coagulation disorders where you can have delayed bleeding, but you still stop bleeding because the primary hemostasis, which is done by the platelets, is still functional. Now, you need to know that factor 7 has a role with the von Willebrand factor, as well as factor 8 has a role with the primary hemostasis. And therefore, you can still have delays in stopping that bleeding, but it's going to be nowhere as severe as if you couldn't form that primary platelet plug to begin with. The PT and APTT are going to be prolonged with coagulation disorders, but they can be normal with platelet disorders because, again, these measure the intrinsic and extrinsic pathways. I'll talk about why you can have a prolonged PT or APTT with platelet disorders. And the bleeding time, as I mentioned, going to be prolonged with platelet disorders, but normal with coagulatory disorders. We touched briefly on hemophilia. So what is hemophilia? Well, it's an X-linked recessive bleeding disorder, and it's going to be more common in males since males only have one X chromosome. In terms of its types, there are 3 types: hemophilia A, B, and C, depending on the deficiency. So hemophilia A is factor 8, 9, and then factor 11. Hemophilia C is particularly more common in Ashkenazi Jews. In terms of its presentation, because this is mostly an issue with factors and not platelets, you would have a very typical presentation of coagulatory issues. So easy bruising, bleeding within muscles, bleeding within joints, right? The treatment is going to be on replenishing the factors that are obviously low in levels, and this will depend on a few things. Firstly, their severity. We can calculate the actual amount of factors they have in their blood, and well, what percentages of the normal levels do they have? And this can be categorized into mild, moderate, and severe. But the mainstay of treatment is still going to be around their clinical situation. So we would only consider giving the missing factor if either they're acutely bleeding, if they're symptomatic, or if they're expected to undergo a major procedure. When we also are considering procedures, we know they're going to be at a high risk of bleeds, so we can give an anti-fibrinolytic medication, which would reduce their risk of bleedings. Does that kind of make sense? So fibrinolytic means it would break down fibrin. We don't want to break down fibrin because that's going to help with the clotting cascade. So we want to give something that blocks the breakdown of fibrin. I hope that made sense. What is von Willebrand factor? So von Willebrand factor is an autosomal dominant disorder. It's the most common hereditary blood disorder. And VWF has 2 functions. So we already talked about how it helps with platelet aggregation. However, it has a second function. It holds factor 8 and is closely linked to factor 8. By linking to factor 8, it increases its bioavailability in the blood, and therefore, with von Willebrand factor or with von Willebrand disease, you can also have low levels of circulating factor 8. If you go back a few slides, you would notice that factor 8 is, where's factor 8 found? So factor 8 is found within the intrinsic pathway, right? Right here. And therefore, with von Willebrand disease, you can have deficiencies in the intrinsic pathway, which would be reflected as a prolonged APTT. However, the severity of this is going to be nowhere as severe as hemophilia A. But just I still thought I'd mention that because you can have abnormalities in the abnormalities in the APTT with platelet disorders, which is what von Willebrand disease predominantly is. The presentation is going to be very similar to our platelet disorders, so easy bruising, epistaxis, nosebleeds, bleeding gums, heavy menstrual periods, and so on. So your typical platelet deficiency pattern. Now, some other important conditions when it comes to bleeding that I thought I'd cover to be super thorough. Leukemias, we've already discussed leukemias extensively in the heme malignancy lecture, so go watch that if you haven't. We have this thing called ITP, which is immune or idiopathic thrombocytopenic purpura. Let me break this down. Immune means that it's your own body's immune system. Thrombocytopenic, meaning you have low levels of platelets. Purpura refers to the purplish discolorations that are large in size. That is a cuteness manifestation of low levels of platelets in the severe form of ITP. Now, what happens in ITP is that you have an immune-mediated destruction of platelets, which is commonly after an upper respiratory tract infection, a UTI, excessive periods of stress or physical activity, and you basically start destroying platelets. As your platelet levels start dropping, you can have symptoms of platelet-mediated bleeding. However, this is going to be quite rare. You can treat them with a short course of steroids, and they usually respond well. You can also consider things like IV immunoglobulins, and surprisingly, you don't really give them platelets. And this actually was an exam question for our year, where we had a woman presenting with what very obviously was a history of an ITP-like presentation. And she had some petechiae, recently had an upper respiratory tract infection, and they asked what the mainstay of therapy would be. And the answer was a short course of dexamethasone or prednisolone. You would only replace platelets if they are severely deficient. And when I say severe, I mean really, really low, or if they're acutely bleeding. Next, we have thrombotic thrombocytopenic purpura, or hemolytic uremic syndrome. Now you may be wondering, well, what is hemolytic uremic syndrome? Hemolytic uremic syndrome is a microangiopathic phenomenon. What I mean by that is micro meaning small, angiopathic meaning vessels. So within your tiny, tiny vessels, you have high levels of platelet aggregation and tiny, tiny platelet clots. This is common in children following mostly GI infections to things like Shiga toxin. Because you now have these microclots, as the blood flows past these clots, it is likely to hemolyze. And as you start to hemolyze blood, it tends to be filtered, and therefore you excrete this in your urine and can have issues with your kidneys. And quite typically, it can present with hematuria as well. So that is your hemolytic uremic syndrome. And obviously, as you start using up and breaking down those clots, you can develop a thrombocytopenia. Next, we have Henoch-Schönlein purpura. Henoch-Schönlein purpura is, again, a predominantly pediatric condition that presents with the triad of renal impairment, arthralgia, and a palpable purpuric rash, typically on the buttocks. Senile purpura is something very similar, but as the name suggests, senile just means old age, and it's commonly seen in older populations. Non-pathological, do not do anything about this. And then you have disseminated intravascular coagulation, which is this horrible, horrible complication of sepsis, and is something we specifically look out for with meningitis in children, because, as you know, DIC can be a complication of meningococcal septicemia and is a big, big red flag that we're always worried about. And that's the end of today's presentation. Thank you all for coming in. I know this was a bit of a big one and can be quite confusing at times. So if you have any questions, chuck them. I was going to say chuck them in the chat, but there's no chat. You can either message me on Facebook or email me. And as always, please look after yourself and please look after your loved ones.